The following podcast is part of a certified educational activity titled Optimizing Precision Medicine in Gastric Cancer Care, Essential Guidance on Translating Scientific Advances with Novel HER2-Targeted Therapies and Other Agents into Current Clinical Practice. Access the entire activity and complete the post-test at peerview.com/VBJ860. Downloadable slides and practice aids are also available.
Hello, and welcome to this webcast on optimizing precision medicine in gastric cancer care, essential guidance on translating scientific advances with novel HER2-targeted therapies and other agents into current clinical practice. I'm Dr. Josep Tabernero from the Vall d'Hebron Institute of Oncology in Barcelona, Spain. I am joined by today's presenters, Dr. Geoffrey Koo from Memorial Sloan Kettering Cancer Center in New York, and Dr. Koei Shitara from the National Cancer Center Hospital East in Japan. In today's presentation, I will first be presenting on the importance of biomarker testing strategies in gastric cancer as we move towards personalizing medicine in this field. Then Dr. Geoffrey Koo will discuss how we can enhance the standards of care by optimally selecting patients for targeted therapies. And Dr. Koei Shitara will walk us through the exciting advancements happening in the HER2 space, including the promising data on ADCs. Lastly, I will conclude with a look at other targeted strategies and examine the future outlook on the care for patients with gastric cancer. Without any further delay, I'm going to move forward with the first topic, biomarker testing strategies to improve treatment selection. Gastric adenocarcinoma continues to be a leading cause of cancer death globally. Even being the third or the fourth, depending on the years, it's an important deadly disease. And we know that there is a wide geographical variation with more than 50% of new cases occurring in developing countries. There is actually a 15 to 20-fold variation in the risk between the highest and the lowest risk populations, and as you can see in the cartoon on the right side. We have had several advances during the last years in terms of understanding more and more the biology of the disease. Several studies have evaluated the molecular features of gastric adenocarcinoma, and one of the most relevant ones are the data provided by the TCGA and the different updates that we have had on this particular study. Importantly, according to this classification of the TCGA launched in 2014, we have at least 4 different subtypes of advanced or gastric adenocarcinoma. When we consider treatment planning, all the guidelines, and including here the ESMO guidelines, show that it's very important to have a multidisciplinary evaluation of the patient before we start any treatment at all. And this is one of the tumors where the multidisciplinary approach has shown better opportunities for patients. And this, of course, includes surgery, systemic therapy, radiation in some instances, of course, always supportive care and nutritional support. If we now move forward to one of the seminal assessments, molecular assessments in gastric cancer, this was paramounted by the first data showing that a proportion of patients with gastric cancer could have also HER2 overexpression or amplification following all the data that had been shown before in patients with breast cancer. And in here, we have classifications on the expression of HER2, either by immunohistochemistry done in the surgical specimens or by the immunohistochemistry done in biopsy specimens, and these are usually samples with a limited amount of tissue. And either with one pattern or the other, we have set a recommendation on 3 positive different scorings. The first one is 1+. This is considered actually to be negative because we have fair expression of HER2 in few cells, depending whether it's a primary tumor, a specimen, or is a biopsy. The second one, and this is more important for the discussion, is a weak to moderate complete basolateral or lateral membranous reactivity in more than 10% of the cancer cells if we look at the primary tumor, and a correspondence if we look at the biopsy specimen. And in this case, we consider the expression still equivocal at this time. And the third one is the 3+, and this corresponds to a strong, complete basolateral or lateral membranous reactivity in 10 or more % of the cancer cells. And this has to be considered positive expression. What we know in here is that 3+ by immunohistochemistry is considered positive, but for the 2+, we have to perform each determination to determine whether the tumor has amplification or not by this ICH technique. Also, important features when we compare gastric cancer or gastroesophageal junction cancer with breast cancer. Naturally, we know that in patients with gastroesophageal tumors, there is more heterogeneity of HER2 expression by immunohistochemistry. We also know that the possibility of false negative testing is higher, and this is the reason why we recommend to have as many samples as possible from endoscopy, because we know that if HER2 expression is analyzed in 5 or less samples, this can lead to a false negative rate as high as 9%. Also, we know that the HER2 protein expression is absent in the luminal membrane, so very important to look at the basal and lateral pattern of the expression. Another important marker that we are more and more using in patients with gastric cancer is what relates to the MSI and microsatellite instability or mismatch repair absence or deficiency in patients with this disease, like in other diseases. Polymerase chain reaction for MSI or immunohistochemistry for mismatch repair testing should right now be considered for patients who are candidates for treatment with PD-1 inhibitors. Regarding the mismatch repair interpretation, the loss of nuclear expression of one or more mismatch repair proteins show a deficient mismatch repair status, while the no loss of nuclear expression of those proteins show no evidence of deficiency in the mismatch repair system, and therefore low probability of MSI high status. If we now move to the MSI interpretation, we have the MSI stable patients, then we have the MSI low patients, and these are those that have between 1 and 29% of the markers showing instability in 1 out of the 5 NCI or mononucleate markers exhibiting instability. And finally, we have the target population that relates to MSI high, and in this case, we have 30% or more of the markers exhibiting instability in 2 or more out of the of the 5 NCI or mononucleotide markers showing instability. Also, for what relates to immunotherapy, we are looking to PD-L1 evaluation, PD-L1 testing, and the FDA-approved companion diagnostic test for the use on formalin-fixed paraffin-embedded tissue is available as an aid to identify those patients that could be more sensitive to PD-1 inhibitors. The PD-L1 expression in gastric cancer is determined for what we call the combined positive score, and this relates to the number of PD-L1 staining cells, including tumor cells, lymphocytes, and macrophages, related to the total number of viable tumor cells, and this is usually expressed in percentage. And as you can see in this cartoon, we see on the left side the sample of one patient that is PD-L1 negative, and on the right side, the expression of a patient that is PD-L1 positive. And now I'm going to be introducing one case, because we like also to put this in perspective with the information coming from cases. This is a 65-year-old patient that we will call Thomas. Thomas has been recently diagnosed of stage 4 gastroesophageal junction adenocarcinoma with metastasis to the lungs and with an excellent performance status, ECOG performance status of 0, Then we order the HER2 testing in the pathology specimen, and our pathologists come back using the immunohistochemistry testing for HER2 evaluation, and he reports back that the score was too positive. And at this point, I would like very much to introduce Dr. Ku and Dr. Shitara, and I would like to have their opinion on what we should do to rule out whether this patient is really positive for HER2 or not.
Dr. Tabanero, thank you so much for the introduction and for going through the background information so clearly. So, based on your slides, I absolutely would agree that the next step, the next standard step, and really it should be a reflexive step, and at most institutions and most labs, will be to go ahead to perform FISH testing.
Sorry, I would test fish as well, and some institutions also test as a dish. So if patient status is very good, we should wait for fish and dish.
Thank you for your comments. Actually, the pathologists from the institution actually decide to go for the next step for testing the patient with the ISH testing. So importantly, it's fundamental that we discuss during this session how important is molecular testing right now. And we understand and acknowledge that the field has changed over the last years, but as you know, and you have been briefly introduced before, all the guidelines right now recommend HER2 testing and a stratification for that. And also on top of that, for other therapies like immunotherapy, most of the guidelines recommend to test for MSI status and PD-L1 expression in the tumor. And as you can see in this cartoon from one recent review, actually this is going to be really important to understand for the HER2 population the best therapeutic options that we have for these patients. And we are all aware, and this is going to be presented later on, the importance of having a first-line treatment of a combination with a platinum and a fluoropyrimidine with trastuzumab in this population HER2 positive. The discussion is going to be more in the second line, whether we use, when these patients progress to the treatment, a ramucirumab-based therapy, or irinotecan or paclitaxel, or even including patients in clinical trials, or for those patients that are at the same time HER2 positive, but MSI unstable tumors, MSI high, whether we have options with immune checkpoints like pembrolizumab and other immune checkpoint inhibitors. But of course, in here, we are going to hear from the speakers, from the other speakers, how important are going to be the new therapeutic options that have been actually presented in the last months. And without anything more to say, I would like right now to introduce the next speaker, Geoffrey Koo, Professor Geoffrey Koo from Memorial Sloan Kettering, that will introduce us how we can enhance the standards of care with novel targeted therapies in this particular setting of patients with advanced gastric adenocarcinoma.
Dr. Tabanero, thank you so much. And it truly is my pleasure to be here with you today in New York while with both you and Dr. Shitara. So, taking off from what you talked about, I will try to integrate the evaluation and incorporation of biomarkers into the current treatment strategy for esophageal gastric cancer. So I think this diagram will be familiar to any clinician who treats patients with esophageal gastric cancer. I think, as you pointed out, in the first-line setting, the only biomarker that has any clinical relevance at this time is HER2 testing. And as you clearly showed, there should be a sequence in terms of testing for HER2. We start with immunohistochemistry. If a tumor is IHC 0 or 1+, that's negative. We treat this as a HER2 negative tumor, and we move on in terms of the paradigm and pathway. On the other hand, if the IHC is 3+, this is also clearly a HER2 positive tumor, and certainly the inclusion of trastuzumab with chemotherapy would be considered standard. As you mentioned, the only time there is a role for ISH is if the IHC is 2+, which means that it's intermediate, in which case ISH helps to settle whether this is indeed a HER2 positive or HER2 negative tumor. So with regards to HER2-negative tumors, the treatment strategy really has been unchanged for decades. I think most of us around the world would agree that the standard treatment would consist of a fluoropyrimidine platinum doublet. Whether there's a role to add a taxane is debatable and something I will discuss in the next slide. On the other hand, if a tumor is HER2 positive, the TOGA study from 2010 clearly established that the addition of trastuzumab to fluoropyrimidine platinum-based therapy is considered standard of care. For patients who progress on first-line treatment, the consideration of subsequent lines of treatment is very much dependent on their performance status, as well as current symptomatology. As you had mentioned, the standard of care for patients with good performance status, ECOG performance status 0 to 1, is currently ramucirumab paclitaxel. For patients with performance status 2, that's arguably the most challenging population. Ramucirumab monotherapy is a consideration, although its activity is relatively limited. Since ramucirumab doesn't impose additional toxicity when added to paclitaxel, there probably is less rationale for taxane monotherapy for these patients. And certainly irinotecan has the same overall comparable toxicities as paclitaxel or taxanes. So truly, this is potentially a difficult medical decision to make. Finally, there are patients with ECOG performance status 3 or 4, for whom best supportive care alone is most appropriate. There are also rare instances where patients with good performance status may elect to pursue best supportive care alone, although I think this is uncommon in the second-line setting. So touching on first-line chemotherapy, we're all aware that the goals of treatment in patients with metastatic disease is palliation, but of course we're also concerned with selecting the regimen with the most favorable progression-free survival. Considerations that all of us take into mind when selecting chemotherapy for these patients are their age, but more importantly, their functional status, as well as any medical comorbidities. As mentioned in the first slide, combination chemotherapy is universally preferred, and I think the majority of patients are able to receive doublet chemotherapy, especially if there are appropriate dose attenuations. For patients with a truly borderline performance status, we can certainly consider monotherapy with either fluoropyrimidine alone or perhaps a taxane. As mentioned, the addition of trastuzumab to chemotherapy is standard for HER2-positive gastric cancer. I think there is genuine controversy about whether there is a role to add a taxane to a fluoropyrimidine platinum doublet. The V325 study from the mid-2000s established that DCF was superior to 5-FU cisplatin, but this really was at the expense of significant hematologic toxicity, including a rate of neutropenic fever in nearly 1 in 3 patients. Certainly since then, there have been modified regimens that have been evaluated, including the modified DCF regimen from Memorial, which did appear to be significantly better tolerated. Today, a modern iteration is, of course, the FLOT regimen developed by German investigators, and its use or its consideration in the metastatic setting is largely prompted by its activity and relative tolerability in the perioperative setting. Certainly, DCF or similar regimens should be selected only for patients with an excellent performance status. So this is the Kaplan-Meier curve from the TOGA study. And just as a refresher, this was a phase 3 study in which patients were randomized to receive doublet chemotherapy with or without trastuzumab. And as you can see, this was of course, a positive study. In fact, it was the first study where the experimental arm had a median overall survival exceeding 12 months. I would note that this Kaplan-Meier curve is actually from a subgroup of patients whose tumors were HER2 IHC3+ or 2+ and FISH positive. Because you will recall that in the TOGA study, tumors that were IHC 0 and 1+, but FISH positive were also enrolled. Today, we would consider these tumors to be HER2 negative. Despite the results of TOGA, subsequent studies that have evaluated anti-HER2 therapies have actually been negative. This is the RTOG 1010 study performed by the Legacy Group in the US. The results were only just recently presented at ASCO. And unfortunately and surprisingly, this was a negative study. So this is a study in patients with locally advanced esophageal and GE junction adenocarcinomas who are HER2 positive. They were randomized either to standard of care therapy with carboplatin, paclitaxel, and radiation followed by surgery, or to the experimental arm where trastuzumab was added during chemoradiation, but also as adjuvant therapy following surgery. The results took a long time to present as the number of events that were needed in both arms actually was never reached. But nevertheless, at more than 5 years of follow-up, you can see that there's absolutely no improvement in either disease-free survival or overall survival with the addition of trastuzumab. Similarly, there was no improvement in pathologic complete response rates at all. These results are certainly disappointing and surprising, and hopefully biomarker analysis will shed some light as to why this was a failed strategy. In the same vein, unfortunately, there have also been multiple negative studies of HER2 therapies in gastric cancer. In fact, the study that came the closest is the first one, the JACOB study. So this is a study in the first-line setting in which patients received a fluoropyrimidine doublet with trastuzumab as standard therapy. They were then randomized to receive pertuzumab, which is an antibody against HER2 that binds at a different epitope than trastuzumab and prevents HER2 from dimerizing with HER1, which is EGFR, and HER3. So I would consider this to be a near miss. Certainly the study actually improved response rates and progression-free survival with the addition of pertuzumab, and barely missed in terms of an overall survival improvement. It was numerically better. The hazard ratio was 0.84, but the p-value was just short of 0.05. The assumption in my take-home point is that if the study had enrolled a larger number of patients, it potentially would have led to a positive result. On the other hand, all of the subsequent studies truly are negative. Heloise was a study that was based on the idea that in patients with gastric cancer, trastuzumab PK levels are lower than in other diseases. So therefore, the study explored giving a higher dose of trastuzumab, but was flatly negative. Similarly, LOGIC was a study that added lapatinib, which is a tyrosine kinase inhibitor, against HER2 to chemotherapy. This study was also negative, although there seemed to be some slight improvement in overall survival. I would note that in both LOGIC as well as TITAN, which is a second-line study with lapatinib, HER2 positivity was selected on the basis of HER2 FISH alone. Therefore, some tumors may have had IHC 0 and 1+, and therefore not derived benefit from this approach. Nevertheless, in the second-line setting, TITAN, which was an evaluation of paclitaxel with or without lapatinib, was negative. And finally, we have the GATSB study, which evaluated paclitaxel with TDM1, the antibody drug conjugate, which was also negative. I would note that potentially one of the reasons why some of these second-line studies failed is that none of them mandated fresh biopsies at the time of progression on first-line treatment. We now know that up to 30% of HER2-positive tumors do become HER2 negative at the time of progression, and that is a mechanism of resistance to trastuzumab and HER2-based therapies.
Thank you, Dr. Ku, for this detailed presentation on the data from the TOGA study, a study that was positive, but also looking at the subgroups of patients, and more importantly, and relevant for the discussion that we will have later on the other studies done in the first-line setting and in the second-line setting, that, as you summarize, were all had to be considered negative for the primary outcome based on different reasons. So coming back to our patient, the patient that Thomas that had advanced gastric cancer with lung metastasis, we did the immunohistochemistry that was 2+. Later on, we did the ISH test, and that test actually show to be positive for ISH, meaning this that this was a patient that was amplified. And I would like to mention again with what the data that Dr. Ku presented on the detailed forest plot analysis of the different subsets of patients, depending on the expression by immunohistochemistry, but also depending on the level of amplification. And he clearly pointed out that depending on the expression, we could have different levels of efficacy in terms of the hazard ratio for overall survival, although that we understand that this post-hoc analysis, but certainly this is important. And also important to mention that for the data that we have on trastuzumab, it's very clearly shown that in most of the countries, the label relates only to those patients that have HER2 expression 3+ by immunohistochemistry, or HER2 expression and positivity for FISH or ISH. But this does not mean that for further clinical development with other compounds, we should also look at those patients that have any kind of expression of HER2 testing. And this is something that we are going to be mentioning later on with the new ADCs, but also with other potential combinations of immunotherapy plus HER2-targeted treatments.
Great, thank you. So now at this point, we are moving on from first-line therapy to second-line therapy. And again, as Dr. Tabernero mentioned earlier, ramucirumab-based treatment is certainly considered standard of care in this context. So the first study that actually showed a benefit for ramucirumab is the REGARD study, which is shown on the left. And this was a study in the second-line setting of ramucirumab versus placebo. And it did show a small but statistically significant improvement in overall survival of about 1.5 months for ramucirumab monotherapy. It is important to note that ramucirumab monotherapy is associated with an extremely low response rate of only about 2 to 3%. So the major benefit for patients is disease stabilization. Thankfully, the drug appears to be extremely well tolerated. For example, in comparison to bevacizumab, it does appear to be a lower risk of arterial thrombosis, as well as a lower risk of intestinal perforation. So in the US, on the basis of these data, ramucirumab was actually approved in the spring of 2014 as monotherapy. Shortly thereafter, the results of the RAINBOW study were presented. This was a study that was run contemporaneously, but evaluated in the second-line setting, paclitaxel with or without ramucirumab. This study also showed clear benefit for the addition of ramucirumab to paclitaxel. Here, there is a more significant improvement in median overall survival of a little bit less than 2.5 months. Of note, there was a near doubling of response rates when ramucirumab was added to paclitaxel, so that the response rate was 28%. Patients on the study also lived nearly 10 months. So subsequently, the US FDA also approved the combination of ramucirumab paclitaxel, which I think today is considered the global standard of care in the second-line setting. Now, so certainly something not to be missed from a perspective of therapy for our patients is the option of pembrolizumab for MSI cancer. And the original data that led to subsequent FDA approval in the US was based on the seminal study by Yang Li as well as Luis Diaz. And this clearly showed that in any MSI cancer, irrespective of tumor site, the pembrolizumab had outsized benefits. And in fact, when this drug was approved, it was the first tumor agnostic approval for any cancer medication. As Dr. Tabernero mentioned, it is therefore important, certainly at baseline or while patients are undergoing first-line therapy, to assess the MSI status. Certainly the easiest way is with immunohistochemistry, although MSI testing with PCR is also an option. Increasingly, many next-generation sequencing platforms will also provide an assessment of the MSI status. Moving on from the second-line setting, there are now also clear data to support the use of immune checkpoint inhibition in the third-line setting. And these are data from the KEYNOTE-59 study. And again, as a reminder, this is a phase 2 study that had several arms. This particular arm presented nearly 260 patients who were treated with pembrolizumab as either third or fourth line treatment. This is a study that was performed in East Asia and enrolled patients with nivolumab in the third line setting. The patients were randomized to nivolumab versus placebo. And you'll see that there is improvement in outcomes. There's clearly a tail at the end of the curve in terms of both overall survival as well as progression-free survival. I would note that the results of ATTRACTION-2 are virtually superimposable upon the results of the KEYNOTE-59 arm that I just presented. Specifically, response rates were about 12%. I would note, however, that if you look at the Kaplan-Meier curve on the right, progression-free survival is short. Progression-free survival is only 1.5 months, which typically is less time than it takes for any of us to obtain a routine CAT scan. You'll see a sharp decline in progression, which implies that at least half of patients have rapid progression on immunotherapy. That argues that we can absolutely do better. Nevertheless, there is clear separation of the overall survival curves even from the beginning, and this resulted in a landmark 12-month overall survival of 27% in a heavily pretreated population. Again, this study enrolled patients with PD-L1 as well as PD-L1 positive as well as PD-L1 negative tumors. Retrospectively, PD-L1 status was determined. However, tissue from only a minority of patients was available. In addition, this study used a different scoring system. Unlike the CPS score that was used for the pembrolizumab studies, this used a TPS score, which counts positivity only in tumor cells. Based on TPS, PD-L1 did not appear to be a predictive biomarker, and as such, in Japan, nivolumab is approved for all comers irrespective of PD-L1 status. So both of those, well, Attraction 2 was a study that randomized immune checkpoint inhibition versus placebo, and Keynote 59 was a single-arm study which did not have a control. How does immunotherapy fare against chemotherapy? Unfortunately, it appears that the answer is not so well, and then this is with the sobering results of the Javelin 300 study. This is a study in the third-line setting that randomized avelumab versus physician's choice of therapy in the third-line setting. I would note that avelumab is a PD-L1 inhibitor, unlike pembrolizumab and nivolumab, which are, of course, both PD-1 inhibitors. Finally, there is also a new third-line option, and this is the most recent drug to obtain FDA approval, and that was approximately spring of 2019. This is trifluridine, tipiracil, or TAS-102. And this is the phase 3 TAG study presented by both Dr. Shitara and Dr. Tabanero. And this took a page from the playbook of colorectal cancer. This is a study in the third-line setting where patients were randomized to TAS-102 versus placebo. And you do see that there is a slight improvement in overall survival of about 2 months. Unfortunately, the drug itself is associated with a very low response rate. To summarize, these are my take-home points. There are now advances in the molecular characterization of gastric cancer that have allowed us to personalize treatment as well as sequence treatment with trastuzumab and the immune checkpoint inhibitors. Nevertheless, despite the early positive studies, subsequent additional studies have been negative. The reasons for this are unclear, but of course are being actively pursued. Nevertheless, there are novel strategies that are emerging, including immunotherapy combinations as well as antibody drug conjugates, and many of these have the potential to transform treatment in the near future. Thank you.
Thank you very much, Dr. Koo. And now it will be my pleasure to introduce the third speaker, who is Dr. Koei Shitara, who will basically address how we can integrate the emerging HER2-directed therapies also with other novel therapies in this setting. But before doing that, let me go back to our case, Mr. Thomas. This is the patient that we diagnosed of advanced gastric cancer with lung metastasis, shown to be HER2 positive, IHC2 plus H positive. And as mentioned by the recommendations also, we decided to treat him with first-line treatment with a combination of 5-fluorouracil, cisplatin, and trastuzumab. This patient actually responded initially to the treatment, but after 6 months with routine follow-ups, we show progression of the disease with new lesions in the lungs. So obviously, under this situation of progression, we discuss with the patient, the relatives, and all the team potential opportunities for this patient, Thomas. And at this time point, I would like to ask Dr. Koo and Dr. Shitara, which are their preliminary thoughts about potential therapeutic options for this patient.
Yeah, I would also love to hear Koei's thoughts, but as I had mentioned, I think there are now multiple data sets showing that up to 30% of HER2 positive tumors can become HER2 negative at the time of progression. So certainly, I would say that our practice would be to try to biopsy a progressive lesion to determine whether it remains HER2 positive or not. In the event that it's not, which occurs a minority of the time, then ramucirumab paclitaxel would be considered standard treatment. On the other hand, if the tumor is still HER2 positive, we would consider any number of experimental strategies, including many of the experimental treatments that Dr. Shitara will discuss momentarily.
Thank you, Geoffrey. Any initial thoughts, Dr. Shitara, before you move forward to your presentation?
I completely agree with Dr. Koo's comment that paclitaxel and ramucirumab is the current best treatment, regardless of HER2 status at second line. And I agree to do a repeat biopsy if possible. Usually, HER2 positive is not overlapping with MSI high patient, but it is better to test MSI test to evaluate the possibility to receive the anti-PD-1 therapy at this stage. So I will treat paclitaxel ramucirumab and prepare patient for further clinical trials or new HER2 ADC.
Excellent, Dr. Shitara. So now, without any further delay, I would ask you to move forward with your presentation.
Well, thank you, Professor Tabanero, for a very kind introduction. And it's my great pleasure to talk about new HER2 targeting therapy. As introduced before, several randomized studies have failed to show survival benefit of HER2 targeting agent, but emerging novel therapy are now investigated in gastric cancers, including new antibody drug conjugate, monoclonal antibodies, new bispecific antibody, and combination with checkpoint inhibitor. So I would introduce some of these treatments. So trastuzumab deruxtecan, also known as TDXD, is a newer HER2 targeting antibody drug conjugate with DNA topoisomerase inhibitor payload with a higher drug to antibody ratio compared with TDM1. Also, this payload as a DNA topoisomerase inhibitor has a very good permeability, which induced bystander effect for HER2 negative cells. So I will introduce it next. In this figure, mode of action of ADC compound is explained on the left side. ADC binds to the HER2 receptor and is internalized into the cancer cell of which expressed HER2. Then linker was cleaved with intercellular lysosomal enzyme such as cathepsin. And this payload attacks the cancer cell, which induced apoptosis because of inhibition of DNA topoisomerase. And then this linker was also released from the cell membrane because of the very good permeability. And this payload also attacks the surrounding HER2 negative cell. This is called a bystander effect. And I believe this mode of action is very important, especially for the tumor type with heterogeneous expression of HER2, like gastric cancer. And actually, TDXD showed a good activity even in TDM1 resistant cell line or mouse model. So safety and activity of this TDXD was investigated in dose escalation and dose expansion phase 1 trial. During this dose escalation study, TDXD as 6.4 milligram per kilogram or 5.4 milligram per kilogram every 3 weeks is considered as a recommended dose for future steps. In dose expansion part, patients with various type of solid tumors with HER2 high expression or low expression were enrolled. In total, 44 patients with HER2 positive gastric cancer were treated within this phase 1 trial with 5.4 or 6.4 milligram per kilogram TDXD. Patient received a median 3 lines of previous chemotherapy, and all patients received trastuzumab. Objective response rate by investigator judgment was 43%, and the median PFS was 5.6 months, and we felt this is a very encouraging result in this heavily pretreated patient population. Most common toxicity are bone marrow suppression like neutropenia, leukocytopenia, and anemia, but most of them were manageable with adequate dose reduction and interruption. We observed 4 patients with ILD or pneumonitis, but one of them showed a grade 3 ILD. So this is one of the important toxicity of this TDXD. So based on this encouraging result, we conducted the phase 2 Destiny Gastric 01 trial. This is a multi-institutional multi-cohort phase 2 study conducted in Japan and Korea. In this presentation, as well as a previous ASCO presentation, we focus on primary cohort for HER2 positive case in the randomized part of the trial. So eligible patients should have HER2 positive status in most recently available tumor sample by central assessment. Patients should also receive at least two lines of previous chemotherapy, including fluoropyrimidine, platinum, and trastuzumab. Patients were randomized to either T-DXd or physician's choice chemotherapy with irinotecan or paclitaxel. The primary endpoint of the study was objective response rate by independent review committee, and the sample size was 180 for this randomized part. And importantly, overall survival as a key secondary endpoint was also statistically evaluated if the primary endpoint for objective response rate showed a significant improvement. So in total, 187 patients were randomized with a median 2 lines of previous chemotherapy. As described in the eligibility criteria, all patients received a previous fluoropyrimidine, a platinum, and trastuzumab. And in also, additional 80% of patients also received a taxanes agent, 70% also received ramucirumab, and 1/3 of patients had previously received checkpoint inhibitors. So this study met the primary endpoint. Objective response rate by central assessment was significantly higher with T-DXd, 51% with T-DXd and 14% with chemotherapy. The p-value was very significant. Confirmed response rate lasting for more than 4 weeks was also higher with T-DXd than chemotherapy, 43% versus 12%. Disease control rate was also higher with T-DXd, 86%, and the median duration of response was 11 months with T-DXd and 3.9 months with chemotherapy. So as you can see in the waterfall plot on the right side, most of the patients with T-DXd achieved some degree of tumor shrinkage. And very importantly, 10 patients achieved a confirmed complete response with T-DXd. This is unexpected in this heavily pretreated patient population. This trial also demonstrated a statistically significant improvement in overall survival with T-DXd. Median overall survival was 12.5 months with T-DXd and 8.4 months with chemotherapy. Hazard ratio was 0.59. And p-value was 0.0097, which was lower than pre-specified significant threshold. So as you can see here, a Kaplan-Meier curve showed a very good separation from the beginning, and the difference was maintained for a long-term period. So 1-year survival rates were 52% with T-DXd and 29% with chemotherapy. So this efficacy result led to the FDA breakthrough designation of this T-DXd for HER2-positive gastric cancers. So looking at the PFS, PFS was also improved with T-DXd treatment. Median PFS was 5.6 months with T-DXd and 3.5 months with chemotherapy. Hazard ratio was 0.47. 1-year PFS rates were 30% with T-DXd and none with chemotherapy. PFS curve were also separated nicely and remained plateau at the long-term follow-up, which suggests a durable response with T-DXd. So this table summarizes the overall safety profile within this study. The most common grade 3 or higher adverse events were bone marrow suppression, which was more commonly observed with T-DXd. Neutrophil count decreased was observed in 51% in T-DXd arm and 24% with the chemotherapy. But most of these events were well managed with dose interruption and dose reduction. GI toxicity were also common, but most of them were with grade 1 or grade 2. And importantly, drug-related interstitial lung disease or pneumonitis was observed in 12 patients by independent review committee. Most of them were with grade 1 and grade 2, and 70% of patients experienced the improvement of this event at the data cutoff for safety. And there is no TLD with this event. But we observed one treatment-related death due to pneumonia with T-DXd. So these results support this T-DXd as a new treatment for HER2-positive gastric cancer at third line or later line, and already these results were submitted for Japanese regulatory authority, and we are waiting for its approval. And then now our phase 2 study in Western patient population is also ongoing. This Destiny Gastric 02 trial enroll patients at second line or later line, which hopefully confirm the promising activity of T-DXd for HER2-positive gastric cancer in a non-Asian patient population. So let's move to the other agent. RC48 is also a new HER2 ADC with MMAE as a payload, as a microtubule inhibitor. In previous ASCO meeting, a large phase 2 study were reported, which enrolled more than 100 patients at the third line or later line treatment with a HER2-positive status. Objective response rate by investigator judgment was 18%, and the response was also observed at fourth line or later line. Common toxicity of this RC48 ADC include bone marrow suppression and alopecia, as well as fatigue. Median PFS was 3.8 months, and median overall survival was 7.6 months. And the other new compound is margetuximab. This is a Fc-modified monoclonal antibody HER2 with enhanced ADCC activity compared with trastuzumab. And this margetuximab showed a single-agent activity for trastuzumab-treated HER2-positive solid tumors in phase 1 trial. Gastric cancer patient also showed some response. So in gastric cancer field, margetuximab in combination with pembrolizumab was investigated in this phase 1b studies. It showed a 29% response in patients with a HER2-positive status in ctDNA, and 35% response was also observed in IHC3+ population in tumor tissue. And the median PFS exceeded 5 months in both cohorts, which is very encouraging in this treatment setting. So now to confirm this encouraging activity, phase 2-3 mahogany trials are ongoing. And next compound is a ZW25. This is a bispecific antibody for HER2 with different epitope. Binding site of this ZW25 is the same with trastuzumab and pertuzumab, but this ZW25 as a single agent has a more efficient internalization into the HER2-positive cells, as well as enhanced downregulation of HER2 signaling. And it showed a very good preclinical activity compared with two drugs, trastuzumab and pertuzumab. And this ZW25 showed a very encouraging anti-tumor activity as a single agent. 4 patients with a G-junction tumor with HER2-positive status achieved a response with this single agent ZW25. And now a phase 1-2 study of this ZW25 in combination with chemotherapy with or without anti-PD-1 therapy is also ongoing. And then last topic is a combination with immunotherapy. Anti-PD-1 therapy may potentiate ADCC activity of anti-HER2 therapy. Also, anti-HER2 may enhance the T-cell response after anti-PD-1 therapy. And actually, syngeneic mouse model showed a very good synergistic activity between anti-PD-1 and anti-HER2 therapies. And this small phase 2 study led by Professor Elena Janjijan at Sloan Kettering showed a very promising activity of 4-drug combination with pembrolizumab, trastuzumab, fluoropyrimidine, and platinum agent at the first line. Response rate exceed 80%, and all patients achieved disease control. And 6 months PFS as a primary endpoint was 75%, and the median PFS exceeded 1 year. So this is a very encouraging result. And to confirm these findings, currently phase 3 KEYNOTE-811 is ongoing as a global study. So not only for this KEYNOTE-811 for pembrolizumab trastuzumab combination and the mahogany study for margaret and anti-PD-1 therapy, additional several studies are ongoing to investigate anti-PD-1 and anti-HER2 therapy. For example, Destiny Gastric 3 trials investigate TDXT in combination with several chemotherapy or PD-L1 durvalumab therapies. GW25 combination with checkpoint inhibitor or RC48 ADC in combination with checkpoint inhibitor are also under investigation in clinical trials. So at this time, first-line standard treatment is trastuzumab plus chemotherapy based on TOGA study, but several promising reports suggest that the combination with checkpoint inhibitor may improve this outcome. So to confirm it now, our large phase 2 or phase 3 studies are ongoing at first line. And second line, paclitaxel ramucirumab is still standard, but we have a promising result with our HER2 ADC at third line, and now phase 2 trial is ongoing at second line or later line in a Western patient population to evaluate this TDXT activity.
Thank you very much, Dr. Shitara, for this excellent view and also very importantly on how things are moving forward in this field of HER2 setting. So I will cover in the next minutes major updates that we have with other therapeutic approaches in this field of advanced gastric cancer. Phase 2 study with cohorts of Kofiri with ramucirumab and paclitaxel with ramucirumab. And this was a large non-randomized study with more than 100 patients. And what we do see in here is that the combination of Kofiri plus ramucirumab in this population of patients have a median progression free survival of 3.9 months and overall survival of 6.8 months. More interestingly, there is a subgroup analysis of those patients that had been previously treated with docetaxel as a matter of the first line setting or even the preoperative setting. And in here also, we do see a favorable overall survival figure with a median of overall survival of 7.5 months. Moving to the field of immunotherapy, we have seen updated data from the KEYNOTE-61 study in the second line setting that compare pembrolizumab with the standard of care, one of the standards of care that is paclitaxel. And we know that although the study for the ITT population was negative for the primary endpoint of the study, overall survival, we have seen that the benefit associated with pembrolizumab appears to increase with PD-L1 CPS score. And as you can see in these graphics, these cartoons, the hazard ratio for the CPS 1 or more population was 0.81, favoring pembrolizumab. For the CPS 5 or more population, it was 0.72, but for the CPS 10 or more population, it was 0.69. Obviously, the numbers diminish as we are more strict with immunohistochemistry criteria for CPS expression, but certainly this is encouraging data suggesting that we may be able to select in a much better way those patients that do benefit from immunotherapy, at least in the second line setting. And also a similar situation we do have in the first line setting. The data of the 62 study was presented on the last year. And we know that the criteria for including patients in this study was CPS staining of 1 or more. And in this particular trial, pembrolizumab achieved the primary endpoint of non-inferiority to conventional chemotherapy in this setting. But also in a post-hoc analysis, we do see that the effect, both for overall survival and median overall survival and the survival curves, it's more favorable for the CPS 10 or more population. We also have seen that the data of the phase 3 Javelin study that evaluated avelumab as a maintenance treatment after patients treated in the first line setting that show clinical benefit from chemotherapy. But unfortunately, the trial did not meet the primary objective of demonstrating superiority in overall survival for those patients that received avelumab. And we are still waiting for the data on the Checkmate 649 study that will be also very important in looking at the effect of nivolumab in combination with chemotherapy in this setting. Moving to the end of this presentation and of the webcast, as we mentioned at the beginning, very paradigmatically, we are in a situation where the opportunities for patients with HER2 positive tumors is being expanded. We have seen important data of new ADCs in this setting, the setting of the initial approval of trastuzumab in most of the countries in the first line setting in combination with chemotherapy, but also other settings where the expression of HER2 is not as high as it was for the initial study of trastuzumab, so 2+ ISH positive and 3+, but also importantly, data coming from other combinations that may have relevance in the next future if next studies show the same signal of efficacy. We have seen also that we have opportunities in patients in the second line setting with conventional cytotoxics, also ramucirumab-based strategies, also the data on trifluridine, tipiracil in the third line setting. But I'm sure that in the next months, we will have to refine a little bit more this cartoon, offering new opportunities for all patients with advanced gastric cancer, but in particular for those that are HER2 positive. I wouldn't finish without mentioning the situation that we have right now in most of the countries with the COVID-19 pandemic outbreak, and very importantly, by different bodies through the world. We have set many recommendations on how to deal and how to best care and best treat patients with advanced cancer, including gastric cancer in this COVID-19 situation. So this comes from ASCO, this comes from ESMO, this comes also from cancer centers in Europe, like the Cancer Core Europe strategy. But the bottom line here is that, in the situation that we have also right now with expanded options for treating patients with advanced disease, also we have to deal in the best way that we could treat these patients through the situation of the COVID-19 pandemic outbreaks. Finally, I would like again to thank Dr. Shitara and Dr. Ku for their outstanding presentations. Also to all of you for being here with us. Thank you very much, and I hope you have all a good day. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/VBJ860. This activity is supported by an educational grant from Daiichi Sankyo Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.